So thank you very much. So as Glenda said, so one of my jobs is I get to be Glenda's boss. That's actually one of the better things that's happened to me. That's not one of the hardest things. But what I'm gonna so first of all, I'm really happy to be here. Actually, Glenda's been trying to get me to come for a while. And I was actually embarrassed to come here because Marcus is kind of my boss, and that I'm an associate editor for the journal. And I always thought I was just terrible because I was so late and slow in getting my reviews done in a time. But then he says, no, I'm much better than average, and that's a bad thing for him to have said to me. But it was actually a pleasure to meet Marcus in person. People that don't appreciate it, he does an absolute ton of work for the journal, and the journal is extremely important in the field. And so that's actually much appreciated by everybody in the field. That you're kind of a kidney donor when you decide to become. Hopefully, there's some prestige involved, but it's really very important to do that sort of thing. Now, in terms of my disclosures, as Glenda said, in 2015, I took a job with AstraZeneca, and I am an employee of them still. I still actually have my professorship at Nebraska and my endowed chair, although most of the money from the endowment's been taken away. But prior to the time I came to AZ, I worked with pretty much any company that was interested in COPD or smoking cessation. And so that's of some relevance. I haven't listed them here, but I'd be happy to provide the list of them. None of them since 2015 except for AstraZeneca. Now, what I'm going to try to talk about today, I'm going to summarize this. First, I'm going to give an introduction to COPD, expecting that some of the people here might not know much about that specific condition. And then I'll talk about the role of smoking in COPD, and then I'll talk about the benefits of smoking cessation. Not that people here need to know why it's better to quit smoking, but actually it's controversial. Even now, people say, is it really a good thing to quit smoking? And so there are data, and people say, are there really data that show the benefits? And this is one of the areas where there's real outcome-based data that smoking cessation is good. And then finally, I'll try to get to the questions that might be of some more interest to Glenda, which is that does smoking topography actually matter? And then specifically within the context of COPD is, can you use the lung, where COPD takes place, as a gauge of smoking topography? That is, yes, obviously I care about it as a disease. I'm a clinician. My patients get sick. But on the other hand, can you use this as a kind of a probe of topography? So that's the purpose. Now, COPD means chronic obstructive pulmonary disease. And in a sense, it's kind of the equivalent of the fever, right? You have your body temperature is high, you've got a fever. COPD means that your airflow out is slow. And there's a machine actually invented by a Brit 150 years ago called the spirometer. This is one that's about 50 years old. Actually, right now it'd be 70 years old. And so this is just a chart recorder, and this is spinning this way, and this is the needle, and this is the amount of air that's coming out. It's going this way constantly, so it's the amount of air that's coming out as a function of time. And that's all that's measured, is how much air comes out. And if that's low, you've got obstruction. And then if you haven't got any other reasons to have it, like a tumor in your trachea or something, then you have COPD. It's a very simple definition, really almost the logic equivalent of having a fever. Now, COPD is heterogeneous. So these are all four different guys that have COPD. FEV1 is a measurement that could be made on that machine, this spirometer. It means forced expiratory volume in 1 second. If you look at anything up with COPD, you'll see that number a lot. It's a volume, but it's a volume in 1 second, so it's actually a flow. So this, if you're sort of compulsive and you care about numbers and definitions, you'd say, why are you talking about volume when you're talking about airflow? And it's volume out in 1 second, and so it's numerically the same. And 28 to 34.5% would qualify as severe airflow limitation. That means that these people have, on average, among them, about a third of the air out that you would expect for their size. So these people all have severe COPD, which you can see that they differ for all the other parameters. The MRC means how much dyspnea they've got, and it varies from 2 out of 4 on that scale to 4 out of 4. Their blood oxygen, and these are the units that we use in the United States, which is millimeters of mercury instead of kilopascals. But you can just see that they vary from being higher to lower. That range actually is a substantial clinical range. The 6-minute walk distance is how far you can walk in 6 minutes. It turns out to be a useful test, and it varies from 150 meters, which is not very far, to 540 meters, which is just squarely normal. So the guy on the far left has normal walking distance, actually pretty good, not normal but not so bad, oxygenation, not much dyspnea, and he's got a generous body habitus with a BMI of 30, and the guys under there, they vary for all of these parameters. So the people all differ from each other. So they all have airflow limitations. So the patients themselves are heterogeneous. So that's the first important point, is that COPD is not really a thing in the way fever is not a thing. It's not even really strictly speaking a syndrome, but they share a single physiologic feature. And there's lots of different ways in which you can get airflow limitation. So the simplest way, this is taken from different pictures, and I'll try to give appropriate citations. This is not on the slide, but the picture on the upper left is from Margaret Turner Warwick's Atlas of Pulmonary Diseases. And it's a picture of a person with asthma, and this is a cross-section of the airway. So this is the smooth muscle that surrounds the airway, and it's constricted down. This would be the airway wall, and it's been sort of squinched in so that it's actually markedly narrow. You can sort of see that if it were to relax, it would open up, and so the airflow is really bad. This is somebody's having an asthma attack, and if you gave a bronchodilator, it would open up and it would be much better. It's a great picture because there's inflammatory cells you can see here, which is actually the underlying reason why they constrict so much. That's easy to understand intuitively. And then this is a picture from Jim Hogg at the University of British Columbia. You can sort of see mucus in an airway, and it's easy to understand why that would cause problems. People with chronic bronchitis. A little less clear is this is a picture taken by Marina Saeda when she was a postdoc in Montreal, showing fibrosis and narrowing and kind of scarring in the small airways. That turns out to be an extremely important process in many people with COPD, and it just actually mechanically causes the airways to narrow, and eventually they can be destroyed. And then finally, that's a picture of emphysema on the left. It's a picture given by Uichi Kawanami, a guy in Japan, who was a colleague of mine at the NIH before I went to Nebraska. And that's the hardest to understand, is why people with emphysema would have airflow limitation. And the reason for that is your lung is like a balloon, and you breathe in, and that stretches your lung. And that's active. And then when you breathe out, just normal resting breathing, you just relax and the lung bounces back. The air comes out passively. If the lung has lost its elastic recoil, that can't happen. And that's one of the mechanisms for causing airflow limitation in emphysema. It's a little more complicated than we can talk about if people are really interested. But the important point is that people with COPD can have all of these things going on, so it's going to be heterogeneous in their lung, and cigarette smoking can cause all of these things. Okay, so now we've got lots of heterogeneity, right? They're clinically heterogeneous. They all share a single physiologic abnormality, but there's multiple ways to get it. And so what smoking does to people is not going to be uniform. This is why understanding the topography might actually matter, and that might have impact on how smoking is toxic. Well, smoking is one of the risk factors for COPD, but it's not the only one. There's actually a lot of risk factors for COPD. So smoking itself is, and so is passive smoke exposure. I'm not going to go through the epidemiologic data for either of those. But air pollution is, and it's really interesting. Air pollution is actually a strong risk factor for COPD, even if you smoke. I mean, it doesn't, to me, there's some really important things that are not understood at all. So if you live in Los Angeles, in an area of Los Angeles that has bad air pollution versus an area that doesn't have bad air pollution, you have lower lung function in the lower air pollution area. It affects almost as much as smoking a lot. And it's true whether you smoke or you don't smoke. That is, if you smoke, your lung function is lower, on top of the air pollution. Now, if you smoke, you breathe in gobs and gobs of particles. Air pollution has a lot of particles, but it's not nearly as much as what's in the smoke. So whatever the air pollution is doing, it's doing it in mechanisms that can't just be the same as smoking. It has to be something different, and this is actually not understood at all. Working at dusty trades, being born small, I'll show some data from that, and then all the other things that I'm not going to read through them, can also lead to risk factors for COPD. Now, I show this slide, then I show the next one, because the next one I've just changed the font to try to account for the attributable risk. Okay, so yes, all of those other things contribute to COPD, but at the present time, smoking is as important as all the others combined. So actually, this is just about the same as the size of all the others. The others aren't in proportion to their attributable risk. Now, interestingly, as smoking prevalence decreases in a population, then these other risk factors are going to increase in relative importance. On the other hand, since that takes place, we'll talk about the natural history over the lifetime of the individual, it'll be a long time before we actually see all of that. So these other risk factors have kind of gotten a free ride, in that smoking is so important, and smoking was so prevalent in the population that smoking, in many people's minds, was the same thing as COPD. I mean, in America, 85% of COPD patients will have been smokers. On the other hand, these other things contributed to their COPD. The attributable risk only 50%. And it hasn't been as well studied as you might like, but smoking is still the most important by far. Now, the bottom of that one was genetics, and so this is from the most recent paper it's a GWAS meta-analysis of COPD. There's actually another one similar looking at lung function in the same issue of Nature Genetics. And there's 22 genes that have been identified by GWAS with some risk for COPD. All of them have low effect sizes, just 1% or 2% optimistically. And actually, if you take a look at the genes that are seen here, you see CHRNA2, 5 on chromosome 15, that's just famous as it's probably a smoking gene, although IREB2 is in the same region that may also independently be related to COPD risk, but you also see CYP2A6 shows up. And in fact, this is what you should expect. So smoking is a risk factor, something that makes you more likely to smoke or more likely to smoke more intensely. It should show up as a COPD gene. And actually, these genes show up as cancer risk factors and heart disease risk factors. But there are some things that are probably specific for COPD, independent of smoking. So genetics can make a difference. So what I like to say, and that's actually about COPD, is that COPD people start smoking in childhood, and this is when COPD is beginning for most people. And so in a sense, you can think of COPD as really, and I'll show you the natural history, a geriatric complication of a primary pediatric addictive disease. And so for all of you people that I assume are studying addictions, this is really important. This is really the causative things for most of what we see in COPD. Now, the mechanisms by which smoking does this, and this is going to be crucial in terms of looking at the lung now as a gauge of smoking, is that it causes inflammation. So this is a cross-section of an airway. These are the alveolar structures where gas exchange takes place. There'll be little blood vessels that will collapse here. And all of these brown cells, those are macrophages. This is from a smoker, and that's way more than you should see. And all that brown pigment is stuff that's from the cigarette smoke. It's probably mostly cells rather than mostly smoke, but cells that accumulate, debris that accumulate, and then get phagocytosed. And this is what would be called small airways disease. So this is an airway. You can kind of see the airway wall here. There's some epithelium and some inflammatory cells surrounding it, and it spreads out into the alveoli. This is a characteristic lesion seen pretty much in all smokers. And it's thought to play an important pathogenic role in how you get smoking-related disease. But this is what I do with probably half of my time was I'm a cell biologist, try to understand mechanisms. Of course, it's easy to draw arrow diagrams, and these are all connected with a very complex signaling network. But cigarette smoke activates pretty much all of the cells in the lung, and it does it. I'm not going to go through all these arrows. It can do lots of things to cause damage, and it can do it in lots of different ways. And smoke can also activate complement and activate non-cellular processes leading to damage. And so smoking is going to be COPD is going to be heterogeneous not only clinically and physiologically, and smoking contributes to all those multiple causes, but it can do it by lots of multiple mechanisms. Okay? So, what happens if you smoke? So this is from a paper that Jürgen Vespo and I got into Lancet in 2006. And in the interest of time, I took out the second one, which is the previous version of this, which was published by Ben Burrows in a less prestigious journal 20 years earlier. It shows exactly the same thing, which means that if you pay attention to the old literature, when people forget about it, you can become famous by publishing it over again. You should give citations, which we did. But if you don't smoke, okay, no pack years. This is from the Copenhagen City Lung Study, which is a very good epidemiologic study with excellent data. The average lung function is pretty close to 100% predicted. That's what you would expect. It's a city, there's air pollution, maybe it's shifted a little bit. COPD would be anything less than 80%. So you can see some people are getting the range of COPD, even if they don't smoke. Okay, that's kind of what you'd expect based on what you said. But if you smoke, and this is now in pack years, and I do understand the limitations of that measure, that's what we're going to see mostly. If you smoke enough, you can see that more than half of the people actually get below that level. And probably if you smoke enough, almost everybody will get some measure of compromise. Pretty much everybody gets inflammation. But the majority of smokers will get some degree of lung problems. Now, you will hear said that 15% of smokers get COPD. That's actually a misquote from Fletcher and Pito, and I've got a slide of that coming up. What Fletcher and Pito, who wrote the first natural history of COPD study, said was that 13% of smokers will get a diagnosis of COPD. That was rounded off and misquoted, saying 15% of smokers get COPD, but actually a whole lot of these people never get diagnosed for a whole variety of reasons. And so smoking is the major risk factor for COPD, and most people are at risk. So to summarize for this kind of introduction about COPD, smoking is bad for the lungs. It's actually bad for the lungs in most people. There's some people with variable risk, clearly, but it's bad in most people. Its effects are complex, and there's lots of interactions. There's interactions with endogenous factors, like all of those genes that could be present. There's 22 that I've identified so far, but that's actually only about 10% of the anticipated genetic risk. And there's going to be interactions with other exogenous factors. It's worse for you to smoke and live in Los Angeles in a bad neighborhood, air pollution-wise. So the next question is, does quitting matter? And actually that turns out to have some interesting complications. So this is the graphic from Fletcher and Pito's. It's actually, most of the data was published as a monograph. There was a paper in the BMJ as well. And this is probably the most important visual in COPD, even now. It's wrong, and I'll show you why it's wrong. Actually, Fletcher and Pito knew it was wrong when they did it, but everybody forgot the second figure, which I'll show you in a second. But the concept is that as you get to whatever size you're going to get to in young adulthood, and then if you're never susceptible or you never smoke, then your lung function declines slowly as you age. You're looking skeptical, but you have to trust it. Lung function and a whole lot of other things decline unhappily as you age. I'll leave it to that. If you smoke regularly and you're susceptible, you lose lung function at an accelerated rate. And if you lose lung function sort of into the range of those guys were and that things, you can actually be very severely symptomatic. If you're here, you've only lost 25 or 30% of your lung function. Actually, people are not necessarily very symptomatic. We can talk about why that's the case. And so people are undiagnosed. And what they suggested, and it was a speculation, is that if you quit smoking early enough, you kind of go back to that of sort of normal aging, and that would be good. There was no data. That was a speculation. They also suggested, and this was figure 2 of their paper, which is mostly ignored, is that some people, this would be the accelerated decline here, some people might start off with low lung function, and some of them could remain well, but if you started off with low lung function, you could get COPD even if you didn't lose lung function as rapidly as if you started off with more. Okay, and that was also speculation, but they certainly suggested that as a potential mechanism. Now, interestingly, and this is a paper, Peter Lange is really the principal investigator for the lung aspects of the Copenhagen City Lung Study. This is a very nice paper, and these are data supporting figure 2 from Fletcher and Pito. Okay, so you can see this is now people showing that some of the people actually age and don't lose lung function. Some people have accelerated rates of decline, but there's some people that never achieve maximum lung function, and actually some of them get COPD with even normal rates of lung function. So this is actual data supporting both of the models that Fletcher and Pito did. And it's actually about 50-50. So about half of people probably get COPD because they lose lung function fast. And half of people get COPD for other reasons. So to understand this, we need to understand the natural history of lung function. So this is from a review that we did in Lancet just a couple of years ago. And your lungs start developing during embryonic development. And there's a series of things that have to take place. We can go through that. but then you're born and your lungs continue to grow in childhood, and then they grow a whole lot in adolescence. And when you reach young adulthood and you get to be about your normal or your maximum body size, your lung function's really about as big as it's going to get. And then it enters what's called the plateau phase, which is really, I think, just totally not understood sort of anatomically or mechanistically. And for about 10 years, everything stays the same. And there's actually good epidemiologic data that this actually takes place. And then after that, it begins to decline. And it declines at a very slow rate. That's called normal aging. What normal aging really means, whether it's normal or not, is a semantic thing, but it declines. And actually, all of those parts can be reduced. And smoking can reduce all of them. And I'll just show you the different examples here. So you could have gradual accelerated decline from cigarette smoking, in which case if you started smoking there, that would be early disease. You could, and this is, you could have exacerbations, get episodes of bronchitis and lose a little bit of lung function each time. Smoking can cause that. You could actually go into the old age and actually do okay and then go into an accelerated phase. That can occur. You could have a reduced plateau phase. Smoking can do that too. If you don't understand what causes it, what smoking is doing is you don't understand. And then smoking can do all of these things. So it can impair your growth. There's very nice data from Pittsburgh showing that lung growth in both boys and girls is compromised if you start smoking before your epiphyses close. I don't know if smoking can actually cause early childhood events like infections, but there's epidemiologic data that if children who are exposed to passively to smoke during childhood, and that's their only exposure, they have lower lung function when they're adults than if they didn't have that exposure. And then finally, if you're born small, your lungs don't develop well. I'll show you the data on that. And cigarette smoking actually will cause low birth weight. And the data for that birth weight is a really pretty amazing study by Barker. Barker did this study at Hertfordshire. Actually, I now work at Hertfordshire. And now I can understand why nobody ever moves in Hertfordshire. So the people were born in the early 20th century. They were born and delivered. The babies were delivered at home by home health visitors who recorded all the babies' weights, and then all those records were kept in the county. I don't know where they were kept, but those records survived all the wars and everything. So what Barker made his career on was by collecting all of the birth weights and then tracking what happened to these people at old age, health-wise. And so what's shown here is lung function measured as FEV1, which I explained on the vertical axis as a function of size in pounds. And you can see that the smaller you were, the less your lung function in old age. Okay, and if you were born big, you had bigger lung function. And it's independent of smoking. So if you never smoked, you had the best lung function. That's what you predict. If you were an ex-smoker, it was intermediate. And if you were still smoking in old age, it was the lowest. And if you look at the effect of smoking, which is on average about 600 mLs on this thing, it's about the same as the effect of being born small or being born big. So the developmental aspects that whatever is happening by birth is a big impact on a late life lung function. Probably smoking wasn't important in terms of the low birth weight for these kids, since they'd have been born before 1920s, which probably there wasn't much smoking among women in Hertfordshire then, but it could have happened. So obviously the one that's been best studied is this. This is the sort of the Fletcher-Peatful model. That is, you sort of have normal lung function and you have accelerated decline, in theory caused by cigarette smoking. Does quitting smoking make a difference for those people? And there was a great study done. It was funded by the NIH. It started around 1990, or in the late 1980s actually. It started 1984. 1994, Nick Antonis and first author in JAMA. The study included 6,000 people divided into 3 groups. 2/3 of them got a smoking intervention. The intervention was free nicotine chewing gum, which is the only thing they had at the time, as much as they wanted for as long as they wanted, and a personal smoking cessation counselor to call them up all the time to bug them not to quit smoking for 5 years. That's not a practical intervention, but that was the most potent intervention that they could come up with at the time. And then that group was divided in half. Half got ipratropium, which is a drug that treats COPD, which had no effect whatsoever, and half got placebo. And what's shown here is the people in the placebo group who quit smoking, and actually when they quit smoking, their lung function got better a little bit. It then levels off and then it declines, but this decline is just what you would predict from Fletcher and Pito for the normal aging effect. And the people that continued to smoke, they lost lung function at an accelerated rate. And so quitting smoking, if you manage to do it, is clearly a good deal. Okay. And you also note that these people have pretty good lung function, normal say 83. So it's just this very mild COPD. I show this slide, and I'm trying to make the point is, I was at a meeting recently with a bunch of cardiologists who said there's no data that shows that quitting smoking actually has a positive impact on your lungs if you've been a smoker. It's not true. I mean, I have no idea why cardiologists don't read JAMA, but there you go. Okay. This is a study, it's an observational study published by Cohansel and colleagues. Actually, Peter Langer was a co-author among several other good friends. So it's observational rather than an interventional study, but actually pooled data from 3 large cohorts. And what it shows is it confirms the lung health study, but also shows something else that's important. So what it shows here is this is people that lifelong non-smokers is the solid line. People that quit smoking before age 30, their rate of lung function decline goes back to that of non-smokers. These are people with very early, presumably, and mild COPD. If you quit smoking later, however, the benefits were less. And in fact, if you quit smoking after the age of 40, your rate of lung function decline of 29 mils per year is really pretty close to that of the average smokers of 32 mils per year. And certainly more than that of the lifelong non-smokers, which is less than 20. So quitting smoking early is a good deal, but quitting smoking later isn't as good a deal. Actually, there's still health benefits, no question about that. But whatever's going on in the lung, smoking can induce stuff that may persist after you quit. I know that that's of interest to at least some people in this group too, in terms of how that might actually work. So, what happens when you quit smoking? So this is a paper, and I put this in intentionally, from Matt Niskold is the lead author. It's when he was younger than he is now. He's now shortly after he published this paper, he did a fellowship in my laboratory. He's now a professor at Karolinska and is a collaborator of Glenda's. This is a study where he took 18 smokers. He did a bronchoalveolar lavage. I'll show you what that's like later. Got them all to quit smoking, and then measured a number of different things. And what's shown here is just the total number of inflammatory cells. That's a pretty good gauge of how much inflammation there is. That's in blue, and you see it just goes down. It actually drops by half within a month. Then it declines rapidly, and actually all that gook that's inside the cells, it fluoresces, which makes it really easy to quantify. And that takes longer to go down because the macrophages eat each other, so the fluorescent material stays in the lung longer than the lifetime of the cells, but it eventually is cleared as well. So, quitting smoking is clearly good. If anybody doubts that, right. And the benefits can be assessed. And you can assess the benefits, at least if you measure the effect of smoking in the lung over relatively short time frames, and you can assess them quantitatively. I just showed you a smattering of data. But this then begs the question, is what I really wanted to get to in this talk, is, I'm going to talk about how to see bronchoscopy first. Okay, so this is a picture of Shigeru Ikeda. That's the vertical person. He's the inventor of the flexible fiber optic bronchoscope. And it's a little bit of a paradox that the lung is an accessible organ. And Ikeda invented the bronchoscope because he wanted to be able to diagnose cancers without having to do surgery. So you take the bronchoscope, you stick it down into people's lungs, and you can get samples. And it's actually really easy to do. We wouldn't do the procedure like this anymore. First of all, he's not wearing gloves, and he's not wearing a mask. Fine. But the patient is awake, and the patient is holding his own tongue. So the patient's actually assisting in performing the procedure. Now what you would see, the end of the bronchoscope this is an old-fashioned one, but it's flexible, it's bendable. It's got a hollow tube that you can sample through. It's got 2 fiber optic channels that light goes through so that it's got 2 so that it doesn't make shadows. And then this one's got an objective lens, this is an old picture. And that modern lens would have to have a little camera on the end. You get much better resolution with a little microchip camera, and it takes up less space inside the bronchoscope anyway. And this is what it looks like. So the bronchoscope's gone through the mouth, down the trachea, and it's now in the left main stem bronchus. It's looking at where the left lung branches into the left upper and lower lung, and that's just bronchial mucosa. That's kind of what it looks like. Actually, it's precisely what it looks like. And this is from a person that's got inflammation in their lungs, and it looks red. I mean, and it is. I mean, you see all the dilated blood vessels. That's a kind of inflammation, just like you get on your skin. And you can quantify that. And we developed an index in Nebraska, and you could quantify what we call the bronchitis index. And this is before and after people with COPD have quit smoking. And you can see that their bronchitis index all drops, and it's quantitatively very satisfying. And so you can measure that. Now you can measure airflow. Airflow actually gets better. You saw in the study from in the lung health study that actually people got better a little bit. And you can see that, but the difference here is actually fairly small compared to the variance. The sample size required to see a benefit with a bronchoscopy is much less than what is required to do if you measure lung function, although you can do it. But you can also measure how well the people feel, and if you measure health status, it gets better. This is not as good a measure since it's people know if they've quit or not, and so you get into the psychology of how you interpret, or how do you interpret a test where it's not blinded to outcome. And you can sample the lung like Magnus did by bronchoalveolar lavage. And in this procedure, what you do is you stick the bronchoscope into the lung as far as it will go, and you gently wedge it so it's like a cork in the airway. It's small, so it goes down to the very distal airway. And then you squirt saline in, and it washes out the lung, and you suction it back, and you can get out cells, and you can analyze them. And this just shows what the cells look like. So you actually see them nicely. This is a macrophage, and that's a lymphocyte. This is a neutrophil down here, so you can actually count the different cells. And that's how Magnus got the data. So this is a non-smoker. The smoker would have particles in here that would fluoresce. You can quantify. They can quantify lots of stuff. And if you quantify alveolar macrophages, this is our experiment, and you can see we got the same results as Magnus did. Is the macrophage number decreased about as much as he did. He was doing normal smokers. We were doing people with COPD, suggesting that there may be more things going on. But you still see a decrease in the total number of cells recovered. And you can take pieces of tissue. This is what Ikeda wanted to do. And you can stick a biopsy forceps. That's a big one, but it goes through the bronchoscope, and you take a little snippet of tissue out. It's not really a very big piece of tissue. It's about the size of a poppy seed is what you get. So it's really, seeing everybody looking very queasy here, but it's actually really easy to do. And this is what you get from a smoker. So this is the airway epithelium. This would be the subjacent mesenchyme. This would be the lumen of the airway. These are the epithelial cells, and all these purple things are abnormal. That's mucus globules. And this is a whole lot of mucus metaplasia. This is from a smoker before, from the same study that I just showed you some data from. And this is after. And you can quantify the number of these cells. It's easy to see that actually your mucus-producing cells increase when you smoke, and they decrease when you quit smoking. And this is just that same data quantified. And you can see we actually have fewer dots. We actually were able to get good biopsies with slightly less than 100% of the people, as you might imagine. So, quitting smoking is good. You can see effects short term. You can see effects on inflammation. You can see effects on cellular metaplasia in the airways. You can actually see effects on clinical parameters like health status. I should have put in on the slide physiologic parameters as well, like FEV1. And so if you can see that with quitting, what about just with changing the topography of your smoking? Does smoking itself make a difference quantitatively? And you would expect that it should, right? I mean, with all the heterogeneity going on, the way you smoke may be actually a really important determinant in terms of what actually happens in the lung, both qualitatively and quantitatively. But can you actually measure anything? And can you actually show that you can measure something? And you can look at the amount or type of smoking, and that's what I'd like to conclude with. So this is from a study that we did now a long time ago. It was published in 1990 in the European Respiratory Journal. And what we did is we took a bunch of heavy smokers. They had to all smoke at least 40 cigarettes a day. And in the olden days, there were a whole lot of people that did that. And they had to be willing to cut their smoking in half, but not quit. If they wanted to quit, we encouraged them to do that. We put them in a smoking cessation program, and they got out of the study. And we enrolled people, and this is how much, this is now alveolar cell number on bronchoalveolar lavage for the non-smokers. after the fact, this when you're young, you really get close to the patients and you get more data than you do when you get to be older. So I had good rapport with all of the patients. He was clearly an outlier for his normal cells. At this point, your airways were inflamed. You've got a lot of cells. You said you're not a smoker. Oh, I don't smoke cigarettes. I just smoke marijuana. Well, really? Oh, yeah, just 2 or 3 joints a day. Is that bad? I said, okay, fine. So what do you do with that data point? Well, fortunately, the statistics were still happy without it, so we just included them in there. But this is another interesting story here. But this is the people before and after, and you can see that just reducing their smoking in half. And actually, the exhaled COs dropped by about 40%. Their self-reported cigarettes went from 40 on average, about 44 on average, to about 15. So what's that, by 2/3? And that's actually what we would expect, because we expect them to actually smoke fewer cigarettes more intensely. This one lady who smoked a ton didn't drop at all, and she told us she had done it. She says, well, no, I just told you that, but I didn't want you to kick me out of the study. And but her husband was also in the study, went to jail actually during the study, because he had physically abused her, and she said that she was willing to come back for a bronchoscopy, but not on the same day that he was going to come back, and so she was having lots of stressful life circumstances at the time, and so she really didn't do that. And again, we left her in the thing because we didn't do post hoc interviews of everybody, but that's statistically significant. So just reducing the amount of smoking changes some parameters that you can measure in the lung. But what about the type of smoking? Now, that's actually much harder to do. And so what I'm going to show is a project that we did looking at eclipse. Now, I don't know if people here know what eclipse is. Do you guys know what eclipse is? People shaking their head. Eclipse was a product, it actually may still exist, I think it does, developed by R.J. Reynolds. And the concept is that most of the toxins in smoke come from the pyrolysis of the smoke. The tobacco itself, it's not perfect, but it doesn't really have very many toxins. And so the question is, can you actually get a tobacco product that doesn't burn anything so that it doesn't make toxins? Would that be safer? That was the concept behind Eclipse. Now, there are several different versions of this, and it didn't taste good, so the first product that didn't burn anything was a commercial disaster. So Eclipse actually burns a little bit of what's called tobacco paper. It's processed stuff, and it gives, to give it flavor. And so it generates about 30% of most of the toxins that are in cigarette smoke. It varies from toxin to toxin. For some things, it's actually higher. Okay, so acrolein, for example, is actually about the same, or actually maybe 110% of conventional cigarettes, and that's because there's a lot of glycerol, which is converted to acrolein in the process. But so it's by no means perfect, but it's not the same as it's not the same set of toxins in smoke, and probably less for most of the toxins. So this is people before. I'm sorry, this is non-smokers, and then this is people before and after switching to Eclipse. So conventional smokers, same rules. If they wanted to quit smoking, we encouraged them to do that. But they wanted to do Eclipse, all right, fine. We gave them Eclipse for free, and then they used it. And this is what they had afterwards in their bronchitis index. This is their visible inflammation. That's obviously going to reach statistical significance. And if we looked at alveolar cells, that dropped. If we looked at neutrophils, which are thought to be particularly bad cells. Now, some people are in the normal range. Maybe these will be people that won't actually get bad disease in their lungs. But even they were dropping mostly. But that was statistically significant as a decline. And if we looked at those goblet cells in the airways by biopsy, those declined mostly. There's one or two people that didn't. Certainly I don't understand the outliers there. But statistically, as you can see, it showed measurements there that affected they could be seen in a statistically satisfying way with relatively small numbers. So, with regard to smoking in the lungs, the lung is clearly very sensitive to cigarette smoke, okay, and many other things. And this can lead to disease. The COPD is what I've focused most of my career on, still working on it at AstraZeneca. But the response of the lung is clearly sensitive, not just to smoke, but also to the amount and the type of smoke. Now, when you change smoking topography, you change dramatically the kinds of toxins that are generated. So somebody that smokes one way is going to undoubtedly be having a different toxin exposure than somebody that smokes in a different way. The prediction from eclipse is that from the eclipse experience, that's likely to have differences in what happens in the lung, which may be usable as a gauge for that. So the importance of the lung, I'm a lung doctor, so it's not important, is that it is a target. So that people actually do get lung disease. That's actually really important. We want to try to mitigate that. Getting people to not smoke would be really a good deal for preventing lung disease. But the lung can also be used as a barometer of the effect of smoking. And so it creates opportunities, I think, in important ways to explore the impact of various kinds of things, like smoking topography specifically. And that then gets to what would be the questions you could ask with this, with the technologies that currently exist. Recognizing you can't do bronchoscopies and biopsies in every experiment you might want to do. So first of all, you can ask questions about harm reduction. That is, can harm reduction, what Eclipse was trying to do, can you reduce the harm of smoking? Can you actually reduce the disease burden? And that's a different question than showing you reduce airway inflammation. I mean, Eclipse did that, but it's by no means clear that it causes less disease. And the difference to the individual versus the society is important. So yes, if the smoker switched to Eclipse and got less disease, that might be good for that person. But if more children started smoking because there is a perceived safe way to do it, on net, that seems like that wouldn't be a good deal. And so the harm reduction aspects of this are ones that I think are by no means obvious and will require careful study. Electronic cigarettes obviously generate, at least potentially generate, far less toxins than Eclipse. On the other hand, people dump in all kinds of flavorants about which we know nothing, and so it's got lots of complexity. And then there's questions we can ask about topography. So does the way in which you smoke actually account to some degree of the different kinds of COPD that we've got? I mean, there's some smoking topographies associated with more of that large airways mucus, or the small airways fibrosis, or the emphysema, or making the asthma bad. And then how does this interact with genetics? I mean, are there specific smoking genetic topography things? That is going to actually solve that and we'll be sorting out. Are we in the next December? Yeah. Okay. And submitted. Yeah. You can be accepted after that's submitted by them. And then how do these things interact? I mean, there's all of them going to interact with each other, and they're all going to. There's going to be lots of complexity there. That's going to keep epidemiologists busy for a long time. But then the question is, can the lung actually be used as a kind of a dosimeter? Recognizing that many of the things that we measure in the lung can be measured by ways that aren't just by bronchoscopy. You can measure lung function, or you can measure symptom scores. You can potentially measure biomarkers in blood or even in exhaled breath. Can you use the lung as a dosimeter to try to look at topography per se, or interventions designed to change topography? So to conclude, and I'll just go back to the previous slide, is the lung is a really important organ. Okay, it's important diseases, and for people interested in addictive behaviors in general, and smoking specifically, it's really sensitive to smoking, which means that you want to try to do something about smoking to prevent lung disease, but you can also use the lung as a probe of smoking behaviors. Thank you very much.